We are now into hour 3 of our caregiver training. At this point, I hope you have a good sense of the residents' rights, how to apply personal protective equipment, how to hand wash, and how to identify cross-contamination. Right now, we're going to move into the aging process. So the aging process, the term refers mainly to humans, many animals and fungi, such as, bacterial and some plants and some animals, potentially biological age. So therefore, we're not, mortals. We do go through a life cycle. Furthermore, aging is a biological and a social construct. It usually is associated with dramatic changes in the biological, physiological, and psychological, environmental, behavioral, and social processes. So throughout our different stages of life, our environments change, our behaviors change, our social needs change. In order for us to get a better sense of it, we're going to go deep into this. But pretty much, when we're, aging, the growth of the cells kind of starts to die down. It's not as reproductive. And that's why we start to see, physical changes deteriorate. So we're going to go ahead and proceed with our first video.
In the last century, the human lifespan has increased more dramatically than it has in the last 4,000 years. In the 21st century, people will be leading longer, healthier lives than ever before. And even though aging is a natural process which often entails physical and mental deterioration, older people, like people of any age, can strive for maximum quality of life. Today's tape is going to focus on the physical changes with aging and what you, the caregiver, can do to help the elderly maintain the best possible health. When working with older people, the goal is to maintain and, if possible, increase the amount of participation in life in order to promote physical, mental, and emotional health. Each person has unique needs and abilities. This is as true of the elderly as it is of the young. However, despite our individuality, as we age, we can all expect changes to occur in the systems that make up the human body. Although exactly what kinds of changes will take place and when vary greatly from person to person, aging is inescapable. It's part of the continuum of life. We're going to be looking at the physical changes of each body system as we age. Starting with the central nervous system. Many people think that the elderly have reduced mental capability. Though this is true in some cases, most people can maintain mentally active and vital lives even into very old age. Though the number of brain cells start to diminish after about age 30, there are plenty of brain cells in order to maintain intellectual function for an entire lifetime. In a healthy person, the change in mental functioning is minimal. Sometimes, though, you can see slower completion of tasks and slower decision-making by the elderly that may make it look like the older individual is having difficulty understanding. But this is not necessarily the case. It may be that the individual just requires a little bit more time for processing information and for reacting to it. I'm sure you have experienced zipping down the expressway, as I have, and getting behind someone who's poking along at about 40 miles per hour. As frustrating as that might be, you need to remember that the elderly person that very possibly is the one in the car is moving at a pace that is safe for them to be able to continue to drive. Mild confusion may occur with the elderly, but it's usually not part of the normal aging process. It can be due to medications, depression, or any number of medical diagnoses. Recently, I visited my parents who live in an assisted living facility, and my father, although he's wheelchair-bound, is very mentally alert. On Sunday afternoon, he asked if I would help him go to the bathroom, and in the process of transferring him from the wheelchair to the toilet, he was having a great deal of difficulty, so much so that I needed to have someone come and assist me. This was not my father. In addition, he was having difficulty remembering activities that we had just done. He was not able to recall what had occurred the night before, and I knew this was not part of his normal mental state. So we ended up in the emergency room of the hospital, where he was diagnosed with an acute urinary tract infection and dehydration, examples of what can cause mild confusion. After receiving some fluids to hydrate him and getting on antibiotic therapy, his mental confusion has totally cleared, and he's very mentally alert at this time. So be sure that you report any confusion to the nurse, particularly if it's something new, because it might be a clue to something happening, a medical diagnosis that might be occurring, or a new medication that might be causing it. Ways to help. Promote opportunities for intellectual stimulation. The saying, if you don't use it, you lose it, applies to brain activity as it does to muscles and other organs of the body. One is never too old to learn something new. That old adage that you can't teach an old dog new tricks really is not accurate. You can provide lots of opportunity for stimulation with things like challenging crossword puzzles, discussing current events, teaching them how to utilize email so that they can communicate with family and friends, can all be ways to provide mental stimulation. Be patient with the elderly who are moving or speaking more slowly than you might like. Recognize that they're going at a pace that is safe for them and comfortable. By pushing them along may just increase their frustration and possible falls that can occur. The cardiovascular system includes the blood vessels and a heart. Natural changes in the cardiovascular system occur with aging and can have tremendous health consequences. The function of the heart, as you all know, is to pump blood through the body's blood vessels. In the older person, the heart may pump less efficiently. Blood vessels, or blood flow to the blood vessels, is reduced by about 1/3 by the time we are 60 years of age. Because of this reduced blood flow through the blood vessels, lots of times the elderly people have a sensation of cold. They feel cold much more quickly than we do. I'm sure you've noticed that elderly tend to be more bundled up than we are. Even on warm summer days, they'll be wearing long-sleeve shirts or sweaters to keep warm. So remember, layering is important, and provide them with the extra clothing because of the reduced flow of blood to the extremities. Because of reduced blood flow, blood vessels respond slower to changes in body position as well. Consequently, rapid changes in body position, such as standing quickly, can produce dizziness. Maybe you've experienced jumping out of bed quickly in the morning and seeing stars, possibly, feeling a little dizzy, feeling that you could almost fall over. It's happened to me. It's a result of the blood pressure not having time to adjust to the changing position. It's even more pronounced with elderly people, so it's important if the person is in a lying position, help them to a sitting position slowly. In the last century, the human lifespan has increased more dramatically than it has in the last 4,000 years. In the 21st
Sorry about that. So, the aging process, as she was mentioning in that video, you know, a lot of our seniors, they have trouble with adjustments in their body positions. So when we're getting somebody up out of bed, raise them up slowly. Allow them to sit and dangle their feet for a few minutes before you move them again. This will help their body with the adjustment in position to allow adequate blood flow. So structurally, you know, our muscles lose their muscle mass, they lose their tone, and that's why it's so important that we, you know, exercise on a daily basis, even if it's, you know, 15-20 minutes, just something to help prevent that loss. This change is observed with the loosening of the skin underneath the arms, sagging breasts, thinner legs, arms. We can really notice muscular changes in our residents and ourselves as we age. Skeleton changes also occur. Our bones aren't as strong, they're more spongy, and they're a lot easier to break. So over the years, our bones lose calcium, and so even just the smallest little trip or stumble that we would recover from in our 20s or 30s, when we're in our 60s, 70s, and 80s, would result in a bone break. And so it's really important that we don't rush our residents so that way they don't have any falls. The skin, you know, that kind of goes along with the muscle, right? So when we start to lose muscle mass, the skin starts to lose its elasticity. There's more wrinkles. You know, it doesn't stretch over our body as nicely. We lose our natural oils, so our skins become more dry, more itchy. And so that's why it's really important that, you know, we apply lotion and other vitamin E oils and stuff like that to our residents' skin. We want to maintain a healthy diet that also aids in our skin to be able to keep its integrity. So skin is something that we all tend to notice, you know, probably before anything else that happens to our bodies as we age. The skin becomes thinner as well, and so, you know, before you know, we could, you know, accidentally scrape ourselves against a tree branch or something, and maybe our skin might look a little dry and irritated, where in our older adults, you know, if they were to brush up against that same tree branch, it could, you know, potentially rip their skin open. And that's why it's so important that, you know, we want to make sure, you know, if we have somebody who is on hospice services, that bed rails, things like that are padded, that there's no exposed bolts, because just, you know, slightly bumping up against something like that could rip their skin open. Also, There is skin pigment changes. We might become more pale. We might have what is called brown spots on our skin. So the skin changes as well as we age, and the color, and just the overall appearance of it. Now, there are some skin changes that are not a normal part of the aging process. So, for example, maybe Mrs. Smith didn't have a bunch of, freckles or moles, and all of a sudden she's developing these, and they are, raised and they're bumpy. That's not normal. So anytime you're providing care and you notice a skin change, and that's not part of the normal aging process, bring that up to the med tech so we can have the doctor assess that for potential skin cancers. The other things that changes are our mouth and our nose, our sense of smell, which then affects our eating, our desire to eat, the amount of food we eat. The bone structures in the jaws change. And so you might notice like a lot of our residents, their faces look really tiny, like they don't really have a bone line. Some end up, having to have dentures, and that will change the structure of their face as well, because the teeth aren't holding that jawline together anymore, and so the bone starts to break down. And as they get older, their dentures that maybe they once were wearing might have been fitting properly are now too big, and they're not staying secure, which then creates a problem with their meal intake. So if you notice that you have a resident whose dentures aren't fitting correctly, bring it up attention to the med tech so we can maybe see about getting them some better fitting dentures, because that bone structure does decrease as they age with the dentures. Smells and sensitivities to smells also change in an older adult. They might be less aware of certain odors than a younger person. And so we hear this a lot that, somebody's coming in and they're touring and they're like, Mom's house smells so bad, and I don't understand how she can live in the smell of the house. And it's not that Mom is ignoring the smell, it's that the sensors in the nose that pick up the sense of smell, they're aging and they're not functioning as well. So we do have a change in our smell receptors. Taste. Geez, Mom, she always loved my stew, but now she's lost it. She's constantly complaining that I changed the recipe, and I've not changed a single thing in my recipe in the last 30 years. So the taste in our older adults do tend to change, and especially in men. They might not realize that they're oversalting their food because they can't taste it, and so they're adding way more than they should. So pay attention to that at meal times. If you notice a resident put way too much seasoning, maybe remind them that they've already put it on there, and make sure they're aware, because that could affect their blood pressure. First, sweet and salties, they tend to go, and then their bitter and sour decreases more slowly. So it's something that's like sour milk. They might not realize that they're drinking sour milk because that taste receptor has changed. The other thing that will happen is when their taste receptor changes, their nutrients deficiencies happen, because, well, I'm not enjoying what I'm eating, so why am I going to eat it, right? So also pay attention to that as well. Vision. The number one reason why a lot of our seniors fall is they might not be seen as well as they used to. So there are several eye disorders that can occur as our residents age: glaucoma, cataracts. They might have detached retinas that can sometimes happen with blood pressure changes and so forth. They might be suffering from, multiple sclerosis, and that affects the sensories in the eyes. The distance, so the lens of the eye may lose some of its ability to accommodate to changes in distance. And what this means that they may take a person longer to recognize someone from across the room, or they might not be able to, read signs, or their hands might not, reach that cup of water as easy because they can't judge the distance from, where the cup of water is at location to their hand. The lights. So for a lot of our seniors, sensitivity to light becomes a problem. It creates a glare. So when possible, we want to eliminate, sun glare if they're watching TV. If they have it available, wear sunglasses outside. The eye just doesn't respond to light as well as it used to. Colors in their vision may change, and a lot of times this is because of cataracts, but colors might not be as bright and vibrant as they were before. They can't distinguish between blues and greens and yellows anymore. They might, this might be because a neurological reason. Colors may be very similar shade, and so they can't tell the difference between them. Contrasting colors such as blacks and whites may be more easy identifiable to them, and that has to do with just the way the eyes receive the color. Clothing can be tagged to let somebody know what is complementary and not. So, we see this a lot in our colorblind people. We might say blue goes with green or green goes with yellow, types of things. So there are different ways we can help our seniors adjust if they need that additional adjustment. Depth perception. That's why we really want to encourage our residents not to use the stairs and to use the elevators instead, because they might not realize the depth perception in the stairs. Changes in the eye in older people does affect their mobility. The floor may appear to be rolling. The older people may shuffle along to ensure the flooring is stable. We see this a lot in our Alzheimer's and dementia patients. They kind of do a little shuffle. Changes in depth perception can make it more difficult to judge a height of a curb or a step. So if you're taking them outside, give them an idea that there's a step coming up, up or down, how high the step is, if there's a crack in the sidewalk. It also might be helpful to edge, the curbs and stuff like that. So if we know that, there's a particular area that a lot of people are going to be going on and off, we might see it be painted a bright yellow or something like that, where they can kind of visually see it and it's eye stimulating to let them know that surface is there. So we're going to watch a little video on vision.
Many people you care for will have poor vision, and some may even be blind. Many older people can lose their central vision and have difficulty seeing straight ahead, but they can often still see some things using their side vision. While side vision does not provide any detail, it is usually good enough to see a doorway or if there is someone in the room, even if they can't tell who that person is. Other people can have quite good central vision, but poor side vision. These people might have difficulty seeing someone walking towards them from the side. Some people can have a vision problem which makes everything look cloudy, like looking through a thick fog. Other people can have a vision problem, which makes their vision patchy, where some areas of their vision are blurred or missing or incomplete. People with poor central vision often have difficulty reading, watching TV, seeing faces, the meal or medication you place in front of them, or anything that is small. People with poor vision also have difficulty seeing things like the edge of stairs, a low-hanging tree branch, a rock on the ground, or other hazards. Many older people with poor vision don't actually realise that their vision is poor. Others don't want to make a fuss, so they won't tell you they can't see things properly. It can be difficult to identify people with vision loss. There are signs which may indicate that a person isn't seeing well. They might fall or trip frequently, hold a book or newspaper very close to their face, not look straight at you. They might look slightly to the side of your face. Not want to join in group activities, especially if these involve reading, playing bingo, Scrabble or cards. Not want to go for a walk, even though they are quite fit. Have reduced care with personal grooming. Be frustrated, angry, anxious or depressed. If you think a person in your care is experiencing loss of vision, tell your line manager about changing the way care is provided to help keep them safe. People with vision loss should be encouraged to be as independent as possible. However, some will require special care to make their lives happier and safer. Here are some examples of how you can provide better care. Always tell the person with vision loss when you are approaching and let them know who you are. You can lightly touch their arm or address them by name so they know you are talking to them. Always ask before initiating care. Some people may not want or need assistance. Remember to let them know when you are walking away from them or have left the room. Encourage walking or other forms of light exercise and check if supervision or walking aids are required. Avoid placing people in wheelchairs if they can still walk, even if they cannot see well. If a person needs guidance with walking, you can touch the back of their hand with the back of your hand. This helps them know exactly where you are standing. If you are on the right side, you can touch their right hand with your left hand. Offer your arm to guide them. They can hold your arm just above the elbow. You stand in front and lead, walking at a pace that is comfortable for both of you. Watch out for narrow spaces and doorways. Don't forget to look for obstacles at foot level, head height, and to the sides, and warn the person in advance. You can help a person take their medication by placing it in their hand, handing them a glass of water, and watch them safely swallow. Remember, do not leave medication in a container, as the person may not see them and accidentally knock them over. In consultation with the person, remove trip hazards in the room, such as power cords, rugs, and other items. Don't change the location of personal items or move furniture in their room without asking, even if it appears to be tidier or safer. Check that commonly used items such as reading glasses, tissues, TV remote, clothing, footwear, etc. are kept in the same place to assist a person to easily identify and locate items when alone. Tell the person when you are placing a meal in front of them and explain what the meal is. It is useful to describe the location of where you have placed their food or drinks. Use plates and cups with contrasting colour to the table surface or tablecloth. Avoid using clear glass water jugs or clear drinking glasses. Don't fill cups to the top. Always let a person with poor vision know where you have placed their drink. This will avoid any unnecessary accidents. Offer to help with putting milk, sugar or sweetener in tea or coffee, as it may be difficult for a person with poor vision to do this. And help by removing clear plastic food wrapping as they are more difficult to see for people with severe vision loss. Most people with poor vision need extra lighting to read, do craft, or look at photos. Place a lamp behind them so the light comes from over their shoulder. Direct sunlight can be uncomfortable for people with poor vision. Do not have the person sit looking towards the window when watching TV. Bright light from the window can be very glary. Don't forget, when going outside, sunglasses should be worn, as glare can be uncomfortable and make their vision worse. If someone wears glasses, these should be easily identifiable and cleaned regularly. A useful tip is to keep a photo of the glasses or a photo of the person wearing their glasses in the top drawer so that you know and can check they are wearing the correct glasses. If they have multiple pairs of glasses, these may have to be labelled for better identification. Alert your line manager if you think the person's vision is worsening. The person's care plan may need to be changed. We hope this training has helped you better understand the care needs of people with poor vision and blindness. This training resource was funded by the Australian Government and developed by the Macular Disease Foundation Australia. For more information, please visit
So we saw there how different vision can affect our seniors, but what's up next is very helpful, and it's the vision perception in someone with dementia or Alzheimer's. So many of us don't realize, but there are over 35 different types of dementia and Alzheimer's. Alzheimer's is a form that covers many different categories: Lewy bodies, Alzheimer's, dementia, frontal lobe, encephalopathies. So there are just many of them, but the most common that we're going to probably deal with in our building is, basic dementia and Alzheimer's. So this is really interesting to see how much of their vision field do they actually have with this disease. And hopefully it helps you to provide better care for them.
So with this disease, we know that with your 5 senses, you're going to change in your visual abilities, your auditory processing abilities, but not your ability to hear sound, your sensation and your movement, what you feel and what you do, what you smell, and then what you taste. All of those are going to change, and you lose safety awareness before you lose curiosity. With vision, your field is getting smaller and smaller and smaller. It's particularly important for us to recognize when a person's in early stages of dementia. They're a diamond. And in other words, these are Allen levels. And what we're talking about here is they have vision that's like a scuba mask. They've lost the sides and the top, but the center's pretty good. When they go from that to having binoculars, there's a really important difference, because when you have a scuba mask, what you're going to be able to do is see the plate in front of you and the person across the table. Once you develop binocular vision, you can either look across the table or look at the plate down in front of you. But you can't do both at the same time. It's one or the other. You have social vision or you have a task vision. And every time you switch, you have to readjust everything. So if I'm looking and talking at you, I don't realize something's going on right here. And if I'm looking down like this, I don't realize there's anything out there. And after that, it gets even worse, because now I look at objects and I don't know how to use them. I don't know what they're for. I see it, but I have a hard time identifying what it is and then what you do with it. So I have apraxia. And then I have to figure out, now how do I get started with this? I have to remember the sequence in the organization. So I pick this thing up, and I may know it's a fork, but then how do you use a fork? How do you hold a fork? How do you manipulate a fork? And how do you pick things up? And which things do you use a fork for, and which do you use a spoon for? It gets complicated. And then comes the time when I can't get my two images to line up, and my brain decides, well, okay, we'll just pay attention to one, so I become monocular, and I lose all depth perception. And it's amazing how quickly you can get yourself into trouble, because when you have just one eye looking about, if you were to do this, look at your index finger, and then track your index finger down to touch something on the floor. What you're going to realize is you don't have a sense of how far away that is. And if you're relying on your feet and your legs and the muscles to organize things, they get tricked, because what they're relying on is the visual information to make adjustments, which means you're very at risk for falls.
So remember, when you're in the memory care unit and you're working with our individuals with Alzheimer's and dementia, it's extremely important that we make sure they can see us before we touch them. We don't want to come up behind them and touch, because we can startle them. Same with the side. We want to make sure that we are placing objects such as food and clothing and activities right in the center field of their vision. As Tipa was explaining in that video, as you age, you lose your peripheral vision, and it just kind of shrinks in. And for our individuals with Alzheimer's, they feel like they're walking around with binoculars, and that's probably why they look scared and paranoid a lot of the times, because they can't process everything that's around them. So they might be able to hear sounds happening to the side and behind, but because they can't see more than, an optical, binoculars vision, it's difficult for them to understand what is happening. And now couple that now with they've lost their glasses. So not only do I have a hard time seeing to begin with, and my glasses are gone, my field of vision is very small. So that approach of making sure they know you're there before you touch can help reduce some anxieties and trigger behaviors. The other thing that happens with us in aging is our hearing. Changes in hearing are multiple and can have profound effect on someone's life, especially an older person. Hearing loss causes depression, social isolation, and now topple that with they can't see, right? And so a lot of times when we correct the hearing by making sure they've got their hearing aids in, or maybe go and getting them assessed to get hearing aids, and now they got their hearing aids in, we see behaviors kind of get better because they can at least have one of their senses restored back, right? So individuals who have some degree of hearing loss may not even realize it, and because they don't realize it, they might not be as social and engaged with activities that are going around them. So pay attention if somebody is all of a sudden not as social and not as quick to look over if a sudden noise is made off in the distance. It could sign a hearing loss. When an individual with a hearing loss is in a group, the person with the hearing loss may begin to think that others are talking about him or her, and this induces social anxiety. Group members may not realize the need to face the person when they're speaking with them. And so that's really important that, once again, we're in that line sight, right? And we let them know we're there. We do a soft touch. We call them by their name. So that way they're not only now seeing, they're feeling it, but they're also now got their attention to focus their hearing onto us as well. And sometimes we might have to repeat the question a couple times or speak really loudly to make sure they can hear us. People with hearing loss might also speak really softly, and they think they're being really loud. Or they might just really talk really loud because they can't hear. So those are some of the things that you want to keep an eye out for. Maybe somebody's all of a sudden shouting that didn't used to shout. It can trigger a concern for a hearing loss. There are three major types of hearing loss. There is frequency loss, and this is low and deep sounds that are more readily heard than higher sounds, so they lose frequencies. I don't know if you guys ever been on YouTube or TikTok, and they go, hearing this sound up to this point can determine your age, and your kids are like, "Oh, mom, that hurts my ears," and you don't hear anything. That is the frequency sound test. It kind of gives you an idea how old you are, because when you're younger, the higher pitch tones, you're more likely to hear them than when you're in your 30s and 40s and into your senior years. Conductive hearing loss, sound waves are not properly conducted in the inner ear, making sounds more muffled or difficult to understand. We sometimes hear this in children, right? My younger son, he would talk, but it was not very well. And they, put him through speech therapy when he was much, much younger. And my point was, what is he hearing? Because if I hear banana versus blah, blah, I'm going to call it blah, blah, because that's what I'm hearing. And sure enough, they put tubes in his ears, and voila, he started speaking, and he started to speak better. Unfortunately, because it took a while to get someone to listen to me about that point and do the surgery, he does have some speech issues, which are getting better, but it does affect our speech. So if all of a sudden we have a senior person who is having a harder time pronouncing, words and stuff, it could be that they're not hearing themselves. So that inner ear wave sound is gone. A central hearing loss allows speech to be heard but not understood. Signals from the ear to the brain misinterpret them. So this happens a lot with dementia and Alzheimer's. They're talking, but they're really not making much sense, right? And so this has to do with the way the brain is receiving those signals. Cardiovascular. The heart, like many other muscles, does end up weakening. Arteries and veins become more rigid. They can become blocked a lot easier, restricting the blood flow and the circulation. And under routine circumstances, these changes do not generally alter the daily function of an individual. These changes may be observed when an aged person who has been sitting for a while all of a sudden stands and walks across the room. Unless a few extra seconds are allowed for the heart to supply a sufficient amount of blood to the body extremities, the person may stumble or fall or seem confused. After the heart has had a significant time to pump through their body, the unsteadiness and the confusion disappears. And so once again, going back to that, we're going to set somebody up, right? We want to give them time to let their feet dangle and the heart to have time to get blood to pump to their legs, because we could stand them up. They might not feel their legs and go to take that first step and not realize they stepped incorrectly, and they're going to fall. And so we want to encourage those good habits with our seniors, so that way if they decide to try to get up when we're not there, they know the routine. Okay, I'm going to raise myself up. I'm going to sit here for a minute, make sure my feet are firmly planted on the ground, and then I'm going to get up and walk. And when I'm walking, I'm going to take those first couple of steps a little slow to give my body that time once again to adjust. So it's really important that we pay attention to sudden movements in our residents. The urinary system. This is something that we all probably fear. Please, please, please don't ever call an adult attend a diaper. How humiliating is that to be told by a caregiver or somebody else that you wear a diaper, even if it's necessary, right? We don't want to degrade them. So it's always an incontinent brief, an attend, something that brings a little more dignity to our residents. So please do not call them diapers. That is an absolute big no-no. But the muscles in the bladder do weaken. And that means the impulse to urinate might be, overwhelming, where I feel like I have to pee all the time and I'm not peeing, or I might not realize I have the need to pee and the muscle in my bladder is weak, and so I pee. The bladder doesn't stretch as well anymore, which leads to frequent urination with weakened muscles, and the bladder may not empty completely, which then leads to a urinary tract infection. So we want to encourage our residents to at least attempt to use the restroom every 2 hours, especially as they are, aging and they're getting older. Hey, Mr. Smith, it's 10 o'clock. We got up at 8 o'clock. Let's go use the restroom real quick, and make sure that they are given an opportunity to fully empty that bladder. The kidneys filter the blood more slowly than when you're younger. So as a result, medications remain in the bloodstream for a longer period of time than younger people. Children, they metabolize medications very quickly. Our older adults do not. The changes in the functioning compounds can damage our kidneys and stuff over time. So we got to really pay attention to medications and discuss those with the physicians, and make sure that even aspirins and things like ibuprofens are used when absolutely needed, because they do take longer for them to process through the system. Another one, a lot of the males worry about the most is changes in their reproduction systems. So, a lot of our residents, they do have intimate relationships. And they may see changes in vaginal secretions. For our males, they might not have fully formed erections, or they could be more easily stimulated in an erection. So their prostates might have trouble. And so that's why we want to make sure that they're getting their yearly examinations. When their prostates become enlarged, they might not urinate fully as well in the older male. So our seniors do go through some pretty significant change in their sexual sexual reproductive organs. So memory. I was attending this seminar on Alzheimer's, and it was produced by UC Davis in Sacramento. And, what I had really found interesting is, we all at some point are going to have some memory loss, but there's certain memory losses that are not part of the normal aging process. And, the number one thing that we're all scared of is, am I going to get Alzheimer's or dementia? And how's that going to affect? Because I hear it and I see it and it's everywhere. And what the speaker had brought up in this lecture was that it's not that it's more, common and provident, it's that we are living longer. So when I think about when I was a CNA back in 1998, a lot of my residents were in their 70s and pretty bedbound, not doing too well. And flash forward almost 25 years later, we have residents who are in their 90s and their hundreds, and they're still walking and they're holding meaningful conversations and relationships. And so we now see Alzheimer's and dementia more common, because as our brain ages, these types of disorders do happen more often. And so it's not that Alzheimer's and dementia is growing, it's that we're living longer, so therefore it's having the opportunity to grow in our society. So short-term memory, may decrease. It becomes more difficult to remember events in the immediate past, like what did I eat for breakfast? What did I eat for dinner? Did my daughter come and visit me yesterday? And there's always ways we can help our seniors to maintain short-term memory, like maybe putting a sticky note on their TV, Susie's coming today to visit you, or Susie came yesterday, or you have a doctor's appointment. Another thing that kind of will interfere with our memories as we age is, too much distraction and overstimulation. What you'll sometimes see is, like, if we're having a big group event and we might bring people out of memory care, is some of the memory care people are allowed to come out and some are not. The ones that are usually left behind are the ones that cannot handle too much stimulation, right? Now, listen, I don't remember where I'm out. It's loud, it's noisy, there's bright lights, and everybody's telling me I live here. Whoa, wait a minute. I don't know what you're talking about. So sometimes overstimulation can affect our short-term memory. So we want to make sure that when we're working with our memory impaired, cognitive impaired individuals, that we recognize the ones who can't handle too much stimulation and give them some distraction-free time to make choices and decisions for themselves. Special needs of the elderly. So we all know the basics, right? Many elderly need help in one or more of the daily activities of living. So bathing, dressing, grooming, eating, meal preparation, medication management or reminders, and household chores. A lot of times we will see family members start to bring mom and dad in when the last three on that list are no longer something that they can manage on their own. When an elderly person starts to have trouble with bathing, dressing, and grooming, a lot of families will bring in a caregiver to make sure mom gets up in the morning, mom remembers to take her bath and change out of her pajamas, and maybe provide her a meal or two. But what happens is when mom starts to forget to take her medications at night, mom can't keep up on her household chores when the caregiver's not there, that's when we tend to see families seek help and move their loved one into a care facility. And we have many residents that they need help with all of these on this list. And some of them might need just the reminders like, hey, Mr. Smith, did we take a shower today? Oh, you couldn't remember for sure. Yeah, you didn't take a shower yesterday, and today is your shower day. Let's go take our shower now. Or they might not realize it's 6 o'clock in the afternoon or evening and it's time for their medication. So they might be able to walk and talk and hold all these conversations with you, but they need a lot of prompt to reminders to get them through their day. The elderly have the need to have the following. So they need areas with extra light to help with decreased vision, extra layer of clothing, even in the summertime, as we had heard earlier. And this is because of reduced circulation from their cardiovascular system, walkways free of clutter, and free of hazards. So make sure bookshelves are secure. They don't have like 5 or 6 boxes stacked up high in their room. And not to be overwhelmed by choices. I know I had brought this up before, but offer 1 or 2 options at a time. Don't say, what do you want to wear today, and put them in front of their closet. They might be struck with fear of not knowing what they should pick and become undecisive. Instead, go, do you want to wear the red sweater or the blue sweater today? It is a little chilly, and give them 1 or 2 choices. Give them extra time to complete a task. As caregivers, especially if somebody is out sick and maybe we're short-staffed or something like that's going on, we have a tendency to feel rushed. And when we feel rushed, we might rush our residents. And just give that to me. Let me brush your hair. Well, now that task is being done for me, and before you know it, I have a hard time remembering how to brush my hair because my caregiver is in a hurry and my caregiver's rushing me. And so you're handing me a hairbrush and you don't have as many tasks on your hands today. So you hand me a hairbrush because you got the extra time to spend with me, and now I don't remember how to use my hairbrush. So we want to give them extra time to complete the things that we take for granted to help promote and preserve their independence and their dignity. So please, even if it's an extra 2 minutes, give them that opportunity to do things on their own. Because as I mentioned before, if you don't use it, you will lose it. Not to, be degraded if I can't do a task on my own, right? Don't make them feel like they're not got respect or your dignity because I need help with an ADL. Give them plenty of time to do that ADL and, and allow them to make that decision. It can be a challenge not only for a resident who feels a loss of independence, but it can feel challenging for the caregiver who is trying to ensure that all ADLs are being completed in a timely manner. So it is easy to become frustrated. However, we must remember to remain calm and sometimes a reapproach with the resident in order to reassure or to ensure an ADL is successful might be needed. So Mrs. Smith is angry and mad and yelling at you, I don't want to do it, don't touch me. Walk away from the situation. Go help somebody else and come back to Mrs. Smith. Hi, Mrs. Smith. Let's go ahead and finish brushing our hair. Oh, okay. Because sometimes they might need a moment to process that feeling, and it might take them longer to process that feeling of anger that I have to have help with that ADL. So I'm going to give Mrs. Smith some time to direct her feelings and get through that emotion and come back and go, okay, Mrs. Smith, are you ready? Let's brush that hair. Not, are you feeling better now? Let's go ahead and get that hair brushed. So try to leave our frustration about what had happened, 10, 15 minutes ago when we come back to that resident. Sometimes maybe they don't want things done in a certain order, right? Maybe she brushes her teeth first before she brushes her hair, or vice versa. So that's the other reason why it's really important to know your residents and their routines, because that will help ensure a timely manner of ADLs and make sure that they actually happen. ADLs are essential function of everyday life, not only from a physical standpoint, but a mental. So I don't know about you, but if I actually shower every day, brush my teeth, do my hair, I feel a little bit better than when I first got up. Now, if it's the weekend and maybe I decide I'm not going to shower because it's Saturday and I'm going to bum around and only brush my teeth, I might not feel as optimistic to go out that afternoon and run an errand if I need to, right? So how we provide care for our residents really does mentally impact their behavior, and it might help reduce behavioral disturbances in our memory care folks as well. Recognizing early signs of illness. Sometimes it's hard to recognize when one of our residents is having a change in physical health condition, such as developing a UTI, respiratory infection, or a cardiac problem until it's maybe almost too late. But however, if we keep an eye out for any of the following, we can help with a better outcome of their care. So frequent falls. Maybe Mrs. Smith is falling more often. This could be a sign of a cardiac issue. Maybe she's dizzy. Same thing. Maybe she's got a cardiac issue or a neurological issue that's developing. New or worsening confusion. Maybe she's never been confused and now all of a sudden she never knows what day of the week it is and doesn't know where she's at, can't remember if she ate. This could be a sign of maybe a potential infection. Same with agitation, especially in our memory care folks. If all of a sudden they're agitated or they're more angrier than usual, this can indicate of an infection or something going on with them. changes in eating habits or refusal to eat at mealtime. So if we're, not feeling very good and we have poor communication to begin with, we might not be able to communicate that we're not feeling good. And so one of the ways that our memory care folks might present there's something wrong is, I'm not going to eat, especially, I love peanut butter and jelly, and you're giving me peanut butter and jelly and I'm just looking at it. I'm not eating it. That's something that you need to bring up to the med tech and say, hey, Mrs. Smith, usually she'll ask for 2 peanut butter and jelly sandwiches, but she didn't even eat one tonight. Alert someone so we can get Mrs. Smith looked at. A refusal to participate in activities they normally enjoy. This is, a big red flag, especially for mental health reasons. There could be something going on, and we need to get that addressed with their primary care physician. And then the most obvious is shaking, fever, chills, complaints of pain, abdominal pain, nausea, and vomiting. If your residents are showing any of those, notify MedTech right away. For mental health changes, some of the earliest signs have to do with a sense of recognition that may involve a low mood, sorry, a lack of motivation. They may seem withdrawn. They may spend more time reminiscing about their childhood more than they ever had before, or earlier life experiences, loss of appetite. I usually ate all my food and now I'm only eating half of my plate at dinner time. Maybe I'm using a wheelchair more than I usually do. I'm not using my walker as often as I used to. Increased fatigue. Maybe I am looking tired. And you're noticing that more in me. Report it to the med tech. So once again, remember, changes in normal activity, refusal to see friends and family, refusal to leave their rooms, not eating their meals, changes in mood, new or worsening aggressions. I'm repeating this because all of these are early warning signs of illness and they need to be reported to the med tech immediately. So we're going to go over some videos. This one is an overview of a UTI and how the urinary system works. So let's watch.
Hello, in this video we're going to talk about urinary tract infections. This is an overview, an introduction. It is important to revise the anatomy of the urinary system, specifically the urinary tract. Let us begin by looking at the male. Here we have the kidney. Coming off the kidney is the ureter, which carries urine into the bladder. Here we have the glans penis, and the urethra. Below the bladder we have the prostate. Coming past the prostate and into the urethra is the seminal vesicles, an important part of semen production. Then we have the vas deferens, the actual tube that runs from the testes, and the testes is where sperm is produced. The female anatomy is very similar, except importantly, they have a shorter urethra. With a shorter urethra means that they are at increased risk of developing UTI. Causative agents of UTI are mainly E. coli in 90% of cases. Others include Enterobacteriae, Proteus mirabilis, and Klebsiella pneumonia. They essentially enter the urethra and colonize the area or bladder because of a variety of reasons and risk factors, and eventually can cause a urinary tract infection, a UTI. The bacteria will cause a lower UTI usually, and this can be either cystitis, which is infection of the bladder, prostatitis, which is infection of the prostate gland, and urethritis, which is infection of the urethra. Infection of the lower urinary tract can progress and cause an upper urinary tract infection. This is where infection affects the kidneys. This is called pyelonephritis. Pyelonephritis is serious and can cause acute renal failure. Interestingly, as we know, urinary tract infections are more common in women, and up to 1/3 of women with symptoms of a urinary tract infection have actually negative midstream urine samples revealing any form of infection. That was a side note. But anyway, how does a UTI occur? Let's look at the pathophysiology. Here again is the kidney, the ureter, the bladder, the urethra. Here we have the inferior vena cava, and the renal vein comes from the kidney and enters the inferior vena cava. Behind the inferior vena cava, we have the descending aorta, which will supply the kidneys with the branching renal artery. So what initially happens, one, is contamination. Bacteria contaminates the lower urinary tract because of certain risk factors. Let's just say the bacteria is E. coli because it is the most common in 80% of cases. They initially colonize the urethra and the bladder. This triggers an inflammatory response in the lower urinary tract. Neutrophils are then recruited to this area. As you can see in the bladder, you have bacteria and you have neutrophils. The bacteria multiply and they are able to evade the immune system because of certain virulent factors. E. coli, for example, can bind to cells in the lower urinary tract and hide from immune cells. The bacteria can form biofilms. A biofilm is any group of microorganisms in which they stick to each other, and often these microorganisms adhere to surfaces and it allows them to survive. If this urinary tract infection progresses and left untreated, or if the patient is immunocompromised, has risk factors, the bacteria can ascend towards the kidneys and then colonize the kidneys, causing an upper urinary tract infection. And then from here, if left untreated, the bacteria can spread into circulation via the renal veins, causing worst case septic shock. A big risk factor for developing urinary tract infections, especially in females, is urinary catheterization. Same thing happens. The catheter can introduce infections straight into the bladder if not done hygienically. The bacteria colonizes the bladder, initiating an immune response. Neutrophils enter, further promoting inflammation. Fibrinogen accumulates on the catheter, providing an ideal environment for the attachment of uropathogens that express fibrinogen-binding proteins. After these bacteria initial attachment to the fibrinogen-coated catheters, the bacteria can multiply, and they can again form biofilms, promote epithelial damage, and can seed infection of the kidney. And so the same story occurs. In pregnancy, urinary tract infections are common. Catheterization will almost always result in a urinary tract infection. The reason being is not only is the urethra shorter in women, but during pregnancy, progesterone relaxes smooth muscle, causing stasis of urine, which allows for colonization, especially up to the kidneys. During pregnancy, it is important to perform urine analysis because not only are urinary tract infections more common, but are also asymptomatic. Untreated urinary tract infections during pregnancy can have consequences for the growing infant in utero. So now let's talk about risk factors for UTIs. These include pregnancy, being female, menopause because it's dry in the vagina and the urethra, sexual intercourse, condoms, catheterization, urinary tract malformation, and urinary stones are also risk factors. The signs and symptoms of UTI depend on where the infection is, if it is lower urinary tract infection or if it's an upper urinary tract infection, upper being the more severe. Lower urinary tract infections cause dysuria, pain upon urination, frequency, hematuria, blood in urine, suprapubic discomfort, and a burning urgency sensation with urination. The urine is often described as being cloudy and having an offensive smell. Upper urinary tract infections can have the same types of symptoms, but classically, malaise, fever, rigors, vomiting, and loin flank pain radiating to the back. There can be signs of shock if the infection is more severe. The classic triad for upper urinary tract infections or pyelonephritis is vomiting, flank loin pain, and fever. Another way to categorize UTI is either being complicated or uncomplicated. To put it simply, uncomplicated UTI, the renal tract and function are normal. With complicated, there is decreased renal function based on investigations and symptoms, and potentially is accompanied by an abnormal urinary tract. Let's go through an algorithm of managing a urinary tract infection. It is important to remember that if there is discharge or itch with signs of UTI, perform a genital examination with swab to check for a sexual transmitted infection, STI. A characteristic of STI is having discharge and a fishy smell within the mucus. Other investigations that are performed, importantly a urine dipstick, which will show hematuria, proteinuria, positive nitrates, and the presence of urine microscopy can be performed, as well as a urine microscopy culture sensitivity. Bloods include full blood count to check for infections, CRP, beta-HCG serum to check for ectopic as a differential diagnosis, especially in a young female adult. For UTI, if the urinary dipstick is positive, treat with empirical antibiotics. If the dipstick is negative, but you still suspect UTI, send for microscopy culture sensitivity using the urine sample. The diagnosis of a UTI is having a bacterial growth on a culture plate of more than 10,000 colony-forming units per mil. As mentioned, urinary tract infections are common in females. And so if a female patient presents with an uncomplicated UTI, she is most likely able to go home discharged with oral antibiotics. The treatment of UTI is essentially empirical antibiotics. For lower urinary tract infections, it's typically oral antibiotics, a 3 to 7 day course consisting of either trimethoprim, nitrofurantoin, or amoxicillin. Upper UTI are generally more serious and require IV antibiotics initially, until the fever has settled and then moving on to oral antibiotics. The course of antibiotics are generally longer with upper urinary tract infections. Finally, it is important to know when to refer to a renal specialist or urologist. Refer to a urologist if there is failure of the patient to respond to antibiotic treatment. If there is recurrent UTI, which is defined as having 3 or more in 1 year. Refer to a urologist if men have symptoms of an upper urinary tract infections. And this is because it is very uncommon for men to develop upper UTI, and potentially could be a result of a more sinister anatomical abnormality. Finally, refer to urologists also if there is significant hematuria. Finally, preventative measures for UTI include drinking more water, antibiotic prophylaxis, especially for females with recurrent UTIs, and cranberry juice, although there are arguments for and against this.
We're going to go over different types of pneumonias.
Pneumonia is an infection that causes inflammation in the lungs and results in fluid buildup, fever, cough, and difficulty breathing. It's caused by a variety of organisms, and that is exactly what we are going to discuss in this video. So what are the types of pneumonia? Pneumonia is often classified according to how the patient acquired the disease. Here are the different types. You have community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, and aspiration pneumonia.
So on the 4 different types of pneumonias, the 2 that we're going to commonly see in our building is community-acquired. This usually will happen after a severe epidemic like COVID-19 that affects the lungs, and pneumonia, depending upon the type you get, is easily spreadable. So that would be one type of pneumonia that you would see. The most common that we see is aspiration pneumonia. This is why we need to pay special attention to our seniors after meal times. If it sounds like they're a little gurgly, having trouble and difficulty swallowing, it could be they're aspirating liquids into their lungs or food particles, which will then cause a pneumonia. So please pay attention to our residents after meal times to make sure we're not hearing excessive phlegm that can sometimes develop and signal a trouble with swallowing difficulties.
Community-acquired pneumonia is when a patient gets it outside of the hospital. Hospital-acquired pneumonia, as the name suggests, is when a patient gets it during their hospital stay. And ventilator-associated pneumonia is when it's acquired while the patient is on the mechanical ventilator. And lastly, aspiration pneumonia is acquired when a patient aspirates bacteria into the lungs, usually from food, saliva, or stomach acid. Alright guys, that's it for this one. Thank you so much for watching. If you want to dive deeper and learn more about this topic, be sure to check out some of the other videos that we have here on our channel. Pneumonia is...
So how to recognize early signs of pneumonia, flu, and COVID. These are all respiratory components.
Lung illness can impact anyone at any time. The flu, pneumonia, and COVID-19 are all contagious respiratory illnesses which can be life-threatening if left untreated. All 3 illnesses might require medical attention, but milder cases can be treated at home. Do you know the common symptoms and when to seek help? Are you experiencing fever, cough, fatigue, and weakness? These 3 symptoms are all common with the flu, pneumonia, and COVID-19. Do you also have a shortness of breath, chest pain, or difficulty breathing? These are common symptoms of COVID-19 and pneumonia. These may even be present with the most severe cases of the flu, especially in people with other health conditions. There are other symptoms that are common with just 1 or 2 of the illnesses. Let's talk about the flu. Flu symptoms will come on quickly. In addition to fever, cough, and fatigue and weakness, the flu will often cause chills, along with muscle and body aches and pains. You may also experience a runny nose and watery eyes, sore throat, and loss of appetite, similar to a cold. Let's talk about pneumonia. Pneumonia will often present with phlegm and mucus when coughing, in addition to shortness of breath, chest pain, fever, cough, and fatigue. Let's talk about COVID-19. COVID-19 is something we are still learning about. What we know is that in addition to the common symptoms of fever, cough, shortness of breath, difficulty breathing, chest pain and fatigue, some people may also experience muscle and body aches, loss of taste and smell, headache, stomach ache, diarrhea or vomiting, sore throat, and chills. In severe and rare cases, people may experience pink eye, rash or discoloration of fingers. Some severe cases of the disease may require medical attention, but most cases of the disease can be treated at home. If you experience any of these symptoms, you should seek medical help right away. Fast breathing, difficulty breathing, shortness of breath, difficulty finishing a sentence, or winded when speaking, blue or gray skin color, pain or pressure in chest or stomach, sudden dizziness, blue or gray lips, confusion, dehydration, not peeing, unable to stop vomiting, throwing up, not waking up, not paying attention to anything, crankiness, seizures. Symptoms improve but then come back, such as a worsening cough or fever. Can't take a deep breath? Pain in your chest? Seek medical help immediately. Visit us at www.lung.ca to download your symptoms self-assessment checklist.
So when it comes to flu, COVID, and pneumonia, as you can tell, sometimes it is difficult to tell the difference if our resident has flu versus COVID. Report any suspicion of any of the three to MedTech, and it may be necessary that we go ahead and isolate that resident from others to help prevent the spread. Next, we're going to look at a video recognizing the signs of a heart attack. A heart attack in women can look different than men. And it's really important that if you suspect any kind of cardiovascular issues with a resident, the sooner we report it and we get them for evaluation at the hospital, the more likely they are going to survive it and still have a quality of life.
Our message is simple. There are early symptoms of a heart attack that you can recognize hours, even weeks before a heart attack occurs. Early detection is vital to prevent severe damage to your heart or even death. It's important to recognize the signs of a heart attack and respond by seeking help immediately. Early heart attack care consists of two parts: recognition and response. Recognize the subtle early warning signs. Whenever there is chest discomfort or pressure, become aware. Is the discomfort reoccurring? Does it originate in the center of the chest? Does it subside while resting and reoccur when active? The response to the symptoms must be decisive. Seek medical attention immediately. Early signs of a blockage may occur hours, even weeks before an acute heart attack. To save lives, we must recognize and respond. We've learned that CPR saves lives by intervening when there is an acute heart attack. When the heart stops, we can shock it back into action, but the heart damage has already occurred, and sometimes death cannot be averted. Doesn't it make more sense to check out the mild chest discomfort before complete blockage takes place, resulting in heart damage? We can stop the progression of a heart attack if we are alert to the early signs. Why is this necessary? 85% of the damage takes place in the first 2 hours of a heart attack. If the message of early recognition and response penetrates the country, it may be the force that topples the heart disease as the #1 killer. Heart attacks have beginnings. Become educated to recognize the warning signs: mild chest pain, pressure, or discomfort, reoccurring pain or discomfort in the chest that occurs with activity and subsides while at rest, shortness of breath, a burning feeling in the throat and chin that can be confused with heartburn or indigestion. We need to respond immediately to prevent heart damage and avoid sudden death. Your action can save lives, whether you are experiencing the early symptoms yourself or you are a witness to someone else experiencing early symptoms of a heart attack. You can become an early cardiac caregiver by insisting on medical attention. The more ways we reach people, the better chance we have of stopping heart attacks as the #1 killer of adults in the United States. The message is simple. Share the message to recognize the symptoms and act immediately. Health courses in high schools, community college can teach early warning signs and responses. Paramedics, firefighters, police officers, educators, physical fitness instructors, the general public, and you may be the first responders to someone experiencing the early signs of a heart attack. Your action can save a life. There are actually 3 presentations of heart attacks, and if you are the first person on the scene, you are called the first responder. The first responder is the Good Samaritan who performs CPR, calls 911, or convinces the victim to get medical help as soon as possible. The first kind of heart attack stops you in your tracks. This is called the CPR scene. In the first type of heart attack, we need to know cardiopulmonary resuscitation or CPR and perform it well. The second type of heart attack is where damage is already taking place. The patient is experiencing the elephant sitting on his chest. Call 911 and behave as an executive spouse because the patient usually does not put up much of a fuss and is in severe pain and is very weak. The third type of heart attack is just in the beginning, and the early heart attack care provides a beneficial impact. This is the most difficult time to get someone to seek medical care. The victim will normally complain, but then use excuses such as food poisoning or gas. The patient has minimal symptoms but is in extreme denial. The patient to first responder interaction can be frustrating. The patient may be embarrassed and wants to ignore it. At this point, they can convince the first responder to contribute to the denial. Even paramedics can find it difficult to convince a conscious patient to go to the hospital. This is the reason why the heart attack remains the #1 killer in the adult population. Several hours here can make the difference between a pleasurable and enjoyable life versus cardiac impairment or even death. Be alert, be active, be heart smart, be an early heart attack care provider. Heart attacks have beginnings. Symptoms can begin about 2 weeks prior to a major cardiac event. This is the window of opportunity to prevent death and minimize heart damage. Heart attack deaths kill 800,000 people per year in the United States, but we can cut that number by 50% if people will learn the signs and symptoms of early heart attack care. Signs and symptoms include nausea, pain that travels down one or both arms, jaw pain, fatigue, anxiety, chest pressure, squeezing or tightness, back pain, shortness of breath, or a feeling of fullness. If you suspect someone is having a heart attack, be a good Samaritan and get them to medical care as soon as possible.
So with heart attacks, it might not always be evident to the resident, but it could be evident to you. It's better to get them in and seen than to wait until we find them unresponsive. It's better to be safe than sorry. The next video we're going to move to is sepsis. Many times people think that you can only become septic if you're in the hospital and you've already previously been sick. But many times our seniors can very easily become septic just from a simple urinary tract infection, or if they were to pick up an infection such as MRSA. It's important to recognize a sign of septicemia and report it into MedTech immediately. Once again, with any other illness, if you suspect there's some kind of illness going on, you do not necessarily have to know or identify the type of illness, but report that there's something wrong with your resident to the MedTech so we can get them seen by a healthcare professional.
This is the body's extreme over-response to an infection, and it can lead to tissue damage, organ failure, loss of limbs, and death. The risk of death rises every hour that treatment is delayed, so your ability to rapidly detect the signs and symptoms could save lives. So who is at risk? Elderly patients are at risk of sepsis, as well as people with a weakened immune system, long-term medical conditions, skin damage such as cuts, blisters or ulcers, or people with catheters. Infections from bacteria, fungi, parasites and viruses can lead to sepsis, with symptoms emerging a short time after infection. This also includes coronavirus infection, so it is particularly important to familiarise yourself with the signs of sepsis during the COVID-19 pandemic. What are the signs of sepsis? A high temperature or fever is the most common sign of sepsis, though some people will have a low temperature or hypothermia. Although this observation is important, temperature alone should not be used to identify cases. You can look out for the other signs of sepsis by using the mnemonic SEPSIS. So that is slurred speech, extreme shivering, known as rigors or muscle pain, passing no urine in a day, severe breathlessness. Septic patients often report that they feel as though they may die. And look at the skin. Is there discoloration or mottling? So that's purple, red or patchy areas, which may look like this. Do they have a rash that doesn't go away when you put a glass on it, which is known as a non-blanching rash? And have their lips, skin or tongue turned blue, which is known as cyanosis? In addition, some septic patients experience extreme pain, confusion, or an increased heart rate, though this is not always the case for elderly people who may develop an irregular heartbeat or arrhythmia, or a very slow heart rate in response to severe infection. Spotting difficult cases. Sepsis can be difficult to spot. Signs may be subtle, non-specific, and non-localized. They may just be feeling extremely unwell, and patients who are elderly, frail, or have weakened immune systems may not present with a high temperature. You should therefore look for other signs that their health is getting worse, such as general malaise, which is a feeling of discomfort or unease, agitation, and behavioural change, such as not acting their normal self or eating or drinking less than usual. For this reason, it is recommended that you pay particular attention to the concerns expressed by the person or their family, as they may be much more likely to notice symptoms that are out of character. If you see any of these signs and symptoms, think, could this be sepsis? Assessing risk. When you suspect sepsis, the patient's status needs to be reviewed urgently. According to the National Institute of Health and Care Excellence, this includes taking their vital signs to identify their risk. This involves taking their blood pressure, heart rate, breathing rate, mental state, temperature, and level of oxygen in the blood, if possible, and using a sepsis risk tool, such as NEWS2, to assess the risk to their health. This will allow you and your team to rapidly assess the situation. Find out more in the further reading section at the end of this module.
Sepsis can kill our seniors more quickly than anything else if we don't recognize it. We could think that they're just with the flu or something else going on. They do not have to have a recent hospitalization for this, so please keep that in mind. One of the other types of illnesses that we need to be on alert for is depression. Depression can be just by itself for an unknown cause, or depression can be a symptom of something more serious, such as Alzheimer's. Depending upon the type of Alzheimer's, depression can be the first warning sign of a severe type of Alzheimer's, along with paranoia called Lewy bodies. If your resident experiences any signs and symptoms of depression, alert your MedTech staff immediately and or management. Many times, the resident might not realize how severe their depression is until they have an impulse to self-harm. Please report any concerns you have.
Right now, 20% of older people in the community and 40% of those in care homes will have depression. However, many go undiagnosed and many more untreated. But young or old, with the right interventions, you can reduce the risk factors that lead to depression, and it can be treated.
After I lost John, cooking for one seemed pointless. The garden got overgrown. I didn't hoover, sometimes didn't wash. I'd be in bed a lot. I couldn't sleep though, I'd just worry. I didn't read. Even the TV and radio was too much at times.
Depression can present in many ways, not just feeling low. This means older people may not realise they are depressed. They may experience loss of interest in life, tiredness, low appetite, constipation, pain or poor sleep. Older people can feel worried, become confused and forgetful. They can lose confidence or feel like a burden. In severe cases, they may think about ending their life.
I like to be active, but stopped because of arthritis. I didn't go out. Some days I didn't speak to anyone. Most of my friends have passed now, and I didn't like to bother my daughter.
Loneliness, bereavement, long-term illness, being in care and hospitalisation are risk factors for developing depression. Having a history of mental health problems like dementia can play a role, as can excessive drinking and fuel poverty. This means that depression in later life is common, but it isn't inevitable.
I had a fall and needed a hip operation. I was in hospital after that. My physio said to get out of bed every day, but I didn't. I had a lot of pain. People came round, but I felt so guilty that somehow I was a bad person for causing trouble. They worried I wouldn't cope at home and would need 24-hour care.
Depression can increase the risk of developing other illnesses and can predict the quality of outcomes for hip fracture, strokes, and even heart attacks. It can be hard to spot in older people because the physical symptoms of depression may be put down to other long-term conditions. Older people may also worry about the stigma of having depression, so may not even seek help.
I barely recognised Mum when I visited. She seemed so withdrawn. I was really worried about her. And although she was asked about pain, her breathing and other things, no one asked her how she was feeling. how she was coping with everything. I tried to visit as much as I could, but with work and my own health problems, it was so hard.
It can be difficult for carers seeing their loved ones suffering with depression. Support for them is vital, as they are at risk of depression themselves.
Once it was recognised that Mum was depressed, she got help and so did I. She was started on medication and was referred for talking therapy to help with her grief, as well as coming to terms with her physical health problems. Mum got a social worker too, who arranged support to help her adjust to coming out of hospital. She was put in touch with a lunch club and other community activities, so she's not so isolated. It also meant I didn't worry so much about her being on her own. With the support of the team, Mum went back to her own home.
Yes, you're 80, but you still feel young inside. I still get bored or lonely sometimes. The biggest help was having something to look forward to in the week. I met some new people and got out the house more. Gradually, I began to feel like me again. Oh, I can see now that I was depressed. But there are things I can do to try and prevent it happening again.
If you are concerned that someone might be suffering depression, asking 2 simple questions can be the first step to a further assessment, diagnosis, and treatment. Please, don't ignore depression in older people. Reducing the risk factors can help prevent it. Depression in old age is not inevitable, and it can be treated. So ask the questions. Start the conversation. See the person, not their age.
We get busy as care providers to forget to ask someone, how are you truly doing? So if you're caring for a resident who's recently been in a skilled nursing facility, and maybe they had been there for a long time because they had a fall, they end up losing their home, and now they're in a new facility, take that time to get to know them and make sure they're adjusting well and that they don't fall into depression. Take that time to ask your resident who's been maybe frequently in and out of the ER, how are they mentally feeling and what could you do to help them? And if there's anything that is alarming to you, report it, report it, report it. One of the things that is the biggest concern in our residents is dehydration. Many times they may cut back on their fluid intake because they don't want to have an accident. So it's extremely important to recognize the signs of dehydration and do things to help avoid it.
All right, we're going to talk about signs and symptoms of dehydration. And the signs and symptoms of dehydration are some that we're all taught and some that we're not taught and some that we just forget. So bear with me for a few minutes as we go through these. Signs and symptoms are sunken cheeks, but if the person always had that pallor or is very thin, these may not be the easiest of signs. Sunken eyeballs. They talk about dry brown tongue and dry mucous membranes. I want to tell you that I tried to get a good picture, and I'm sure they're available, but I couldn't find one. on the brown tongue, but I'm more interested in the tongue fissures that you can see that come from dehydration. It almost looks like cracks in the tongue. There's no reason when you're working with residents, you're going to do their oral care or assist someone not to ask them to show you their tongue and look for those fissures and see if you happen to have any one of those 1/3 of people who might be suffering from dehydration. The other thing about the mucous membranes is we say dry, but in a lot of cases it's very sticky. And I think people like myself are under hot lights teaching, and when you don't want to drink a lot of water while you're standing here because you can't leave, your mucous membranes, you can feel your mouth almost get sticky, not so dry. And so those are some things to look at also, not just looking for the dryness. When they talk about dry, inelastic skin, at the very end I'm going to show you some photos, but I want you to understand that as people age, and they lose collagen in their body, their elasticity changes. So where I would pinch my hand and it might go right back down, somebody who's older, already their skin is very loose. So this may not be the best way of checking for dehydration. Weight loss, for sure, we always think of is just in relation to nutrition and into food intake, which I said we would get to, and I promise we will. But weight loss has to be looked at as could this be from dehydration. Concentrated urine is really interesting. When we talk about concentrated urine, there are studies that are done, and I don't know whether anybody has seen these studies or used these, and if you do, please tell me. But there are little wheels that do from like a straw-colored urine all the way to a very dark-colored urine. And they use these sometimes for folks when they first come into facilities to establish what their baseline is. They have not been shown to be 100% effective, but one of the things is we do want to be looking at the color of urine and notifying changes and notifying supervisors and nurses, because even if they have decreased urine output, that's one thing, and that very concentrated urine may be giving us a heads-up sign before they have almost no urinary output. But anybody who's interested in learning more about the wheel can contact me, and I'll try to get you that information, but it was an interesting study for me. Another sign and symptom of dehydration is constipation and impaction. And you have to have so much water or fluid consumption in order to be able to have stools that are going to be able to be passed easily, and so that we don't suffer from the constipation. And of course, by the time we get to an impaction, again, we have a very serious situation for somebody who's older. And looking at impaction is why that is a sentinel event, and dehydration go right hand in hand together.
So it's important that at the beginning of your shift, you offer fluid to all of the residents that are in your care. At meal times, look at how much of the fluid they drink off of their plates. And then during the snacks, make sure fluids are being offered yet again. And then at bedtime, offer them some water before they go to bed. We want to avoid dehydration. Dehydration can cause, as she had mentioned, severe constipation and impaction. And sometimes that does require surgical interventions. So dehydration is a life-threatening condition if it's not caught in time. So the importance of recognizing illness is to report it right away, even if you're not for sure what the illness can be. I would rather someone report something and it be nothing than to ignore it and it becomes something that's life-threatening. Notify the med tech on duty right away. Send a message in when I work. Send an email to Marivic, our director of nurses, or put a note underneath our door. Remember, any changes in the condition of the residents that you care for need to be reported immediately.